here. It's really appreciated and so nice to see you today. I just want to start by doing a welcome to country. So AIVL acknowledges the traditional custodians of the land. We pay our profound respects to elder past, present, and rising. I'm coming to you from Gadigal land and extend my respect to all Aboriginal and Torres Strait Islander peoples present with us, and to all the lands and nations where you are joining us today. Always was and always will be Aboriginal land. I also want to take a second to do a community acknowledgement. So AIVL also acknowledges the legacy of peers who went before us, their crucial work to reduce the harm of HCV and HIV, and the lives of our community members that we have lost. AIVL reaffirms its commitment to fighting the effects of stigma and criminalization in all their manifestations. So thank you so much, everyone, for being present today at this AIVL Consumers Forum on the ODTP changes. It's been a long-awaited change. So we're really grateful for all the consumers, the peers, the advocates, and people from the government who helped make this a reality. This is a crucial step to ensure our community across the country is able to access ODT medication. But we know that this change can be scary. It can be tricky. There's a lot of details in relation to the implementation of those changes. So there will be, as I said earlier, a question time at the end for you to ask all of your questions. But in the meantime, if you want, there's a Q&A section that you can just drop your questions in there, and some of our team members will be starting to answer those questions, and other people can comment as well. Just to let you know that today we really want this to be a safe space for the community and for everybody involved. So respect is absolutely mandatory. Your feelings are all absolutely valid. If you're scared, if you're angry, we understand. We just don't want to have any abusive behavior. So that won't be tolerated. So just remember that we're all there to work together to get some information, some reassurance with what's going to happen over the weekend in the next few weeks. And we want to make sure that no one falls through the cracks and that the transition is as smooth as possible. Let's see if we have David now with us. So I believe we don't have David with us at this point in time. So I'm just going to introduce Kirsten very quickly. So Kirsten is the director of the Alcohol and Other Drugs branch at the Australian government, the Department of Health and Aged Care. David, who's going to join us hopefully later, is the Assistant Secretary of the Pharmacy branch at the Australian government Department of Health and Aged Care. So we know that there's a lot of recent changes, updates, a lot of information for consumers out there. If we don't have David for all those details, Kirsten, is there anything that you would like to for the consumers to know? David can join us later and add more details about that.
Thanks, John. Thanks, everyone, for having us here today. We're really privileged to be able to present some information to you and hopefully give you a little bit more information about what's coming up over the next little while in relation to access to PBS medicines for opioid dependence treatment. So as hopefully most of you have heard, there's going to be some changes so that we make access to ODT medicines more like usual PBS medicines. So starting to look at how we shift access here to make things more affordable and a little bit more equitable, like everyone can access other PBS medicines that they might use. So starting tomorrow, pharmacies are ready to provide people with their doses and to start to transition into an arrangement where people pay the PBS co-payment for their medicines. So the transition here is mostly around people not paying their daily dosing fees at pharmacies anymore. So the idea is that we start to move towards paying regular PBS co-payments up to 20 days supply for your medicines. and the PBS, the daily dosing fees cease. So that's probably going to be the biggest change that you will see. Pharmacies have been informed of this change, and we've been working really closely with them so that they can understand what they need to do to support you and to make sure that you continue to get your dose in the same way that you always have, the same dose that your doctor has prescribed to you. Nothing changes in that regard. It just means that behind the scenes, the PBS mechanics start to kick in, and these medicines will become more like the usual standard PBS arrangement. In addition to that, your PBS copayment that you pay will start to count towards your PBS safety net. So those out-of-pocket costs will start to contribute to your threshold. And so over time, depending on how many other medications people may be taking, you may reach your safety net threshold, and that will change how much you might pay for those medicines. So it might reduce it down to zero, depending on what your individual or family safety net is, or it might reduce it down to a concessional copayment amount. So if people aren't familiar with what the PBS copayment amounts are, so that is $30 for up to 28 days supply if you are a general patient. If you have some kind of concession card, that will be $7.30 for your 28 days supply. So this is quite a big change. And I know that it's, for a lot of people, this has been a really long time in the making. And it is going to take a little bit of time, I think, over the next few weeks for these things to settle and become, more just kind of business as usual as the way these things operate. So we're really looking forward to everyone to kind of work together and to create a really supportive environment so people can continue to access their medicines. For people who may not be getting their medicines in a community pharmacy, but might be dosing at, say, a clinic or another drug and alcohol location, that shouldn't change coming into tomorrow. So the government has put in transition arrangements to support those sites in continuing to get their medicines so they can continue to give them to you while we transition into the PBS arrangements. It might mean that for some people who might dose, say, private clinics, you might need to continue paying your private fees for a little while, just until we can manage and to work with the jurisdiction so that you can move into a PBS subsidised arrangement. But we really have tried here to make this a transition and to make sure that the focus here is patients at the centre and making sure that you can get the medicines that you need and have always had starting tomorrow. I might leave it there, John, as an intro spiel.
Thank you so much for all that details. I know you've been working so hard on this. It's such an important change to have it on the PBS. It really normalize, people being able to access those medication, and it's so important for our community. So we really appreciate the work that you've done with this, you, David, and your teams, I should say. But we also have on the panel some incredible peers with us today. So I would like to start by introducing Aisha. So Aisha is the Client Engagement Officer at Quinn, and she is also an amazing AIVL board member. So Aisha, I would like to check in with you to see how it's going in Queensland. What's the reality? What are you observing? Can you share a bit about that?
Yeah, cool. Well, unfortunately, I don't have much information for Queensland. I've heard that they're in conversation, but nothing has been finalised, so which is quite upsetting for some of our clients. But I'd really like to push that we've got quite a few private prescribers and dosing clinics here, and our private prescribers and especially our pharmacists in the dosing clinics go beyond their expertise to dose our clients. The private prescribers just are completely, utterly awesome with our clientele, especially people that are just getting released from jail. So for an example, I had a client get released from jail 2 days ago and called me, and he only just got out. So he called me from his mum's phone while he was hopping in the car. He had already rung ATODS, which is our non-private prescribers, and there was a wait list of 3 weeks before he could get an initial screen or an intake. So he was like, what do I do? You know, and I said, listen, just try out some of our private prescribers. One of our private prescribers got him in straight away and dosed straight away. So that's the complete difference in our not like in our non-private settings, in our private, I feel that they've just got, I don't know if I could say this, but I'm going to say it anyway, they've got more empathy, you know, and for especially for our clients that are getting out of jail, like my client said, if he waited 3 weeks, he probably would have OD'd and be dead by 3 weeks. And his mum started freaking out. But he was just saying, like, reality is, I've got a habit inside. I need to get on the program, and at 3 weeks to have an intake is ridiculous. What else I'd like to say is I know that our clients are going to love the pricing because it is quite expensive, but the biggest issue in Queensland is that we don't have hardly any prescribers, so we need more prescribers. So that's around about it. But thank you.
Thank you so much, Aisha, for sharing about this. Yes, we have some community members, especially people exiting custodial settings. That's really tricky, and we need to make sure that people are able to access the medication. So thank you for sharing about that and sharing about the fact that you're missing to have more prescribers as well in Queensland. Kirsten, is there anything you would like to add to this?
Thanks, Aisha. Yeah, I mean, we've definitely heard about the prescriber challenges, not just in Queensland, but across the nation. That has definitely been one of the most, well heard, I think, I guess, barriers to actually fully opening up opioid dependence treatment to more patients. And while addressing the financial barrier goes some way to that, it's not the only way. And so we are in active conversations with states and territories at the moment about that issue. We've also been having some conversations with GPs at the RACGP about how we can encourage and promote this as a really great space for GPs to be working in. So while not an immediate kind of for 1 July problem that we're looking at, definitely post that, it's on our radar and something that we'd really like to explore more, particularly with the jurisdictions. Maybe just on the kind of private clinic aspect, I know it's really tough, particularly in sort of transition periods for patients. So out of correctional facilities or even, in and out of hospital or between different dosing sites. So those transition points are really critical, and it's also something that's on our radar to take up further once we get through these kind of immediate PBS changes. But also why we wanted to put those transition arrangements in for the private clinics so that we can work with them a little bit more closely over the next months to work out what the best arrangements are going to be for the clinics, but particularly for those clients. We do really want to make sure people can get access to the PBS subsidised care as quickly and safely as they can in an appropriate way.
Thank you so much, Kirsten. Personally, it makes me feel so much safer to know that you guys are actively working on this and understanding that there is some challenges past the implementation as well. But we really appreciate your help on this and being so open to hear the consumers' feedback or peers' feedback. So if anyone at any point in time has some feedback, please feel free to send it to AIVL and we can forward that to Kirsten and David and their teams. They're really fabulous and the objective of this change is really to help our community, its patient or client or consumers, centered, and I can feel that from the department as well. So I'm sure they will be open to receive some feedback. So please send it to AIVL if you have anything. Just to let you know, for people that are joining us as well, we are recorded. I mentioned it at the beginning before starting the recording, but if you're joining us, just so you know that you're recorded for privacy reasons. And also, if you need to access the closed caption, just click on the more option at the top with the 3 dots, scroll down, click on language and speech, and then turn on the live captions. It's something you have to do yourself. I would like to now introduce Leah, who is the communications lead at NUA. I had the chance to work closely with Leah when I was working at NUA. She's absolutely fantastic and leads crucial community projects like Users News, Insiders News, and the amazing PAC Forum as well. Leah, could you tell us a bit more about what's happening in New South Wales, and if you have any question for Kirsten as well?
Sure. Well, first of all, I'd just like to say that this is absolutely amazing. I just never thought, well, I did think this day would come. I was hoping this day would come. We've been working towards it, but it feels so amazing to finally be seen, to finally be at a point where, we've been told all the time we don't deserve, and that we don't, not only do we not deserve, everything else, but we don't deserve treatment, we don't deserve, we got ourselves into it, so this kind of recognition that we're an important part of the community is just amazing for us, I think. It's been quite full on here in New South Wales. So we have had, people are really excited, but they're also a little bit nervous. So we've had a few chemists that have pulled out, and some of the privates are behaving really badly. But on the whole, I think a lot of people, I said to my chemist, what do you think? And he said, congratulations. I'm so glad this day has come for you. I'm so pleased for you. And of course, we'll be continuing. And I was on a webinar for the Pharmaceutical Society of Australia a couple of nights ago. And there are so many pharmacists who are continuing, and it's not easy. It's not like it's nothing, this transition. Like, there's a lot of work to do. There's a lot of admin stuff that they're not going to get paid for anymore. I mean, it's not like we're the only arrangement like this, and it's not like, it's not like they haven't made a lot of money out of our pain and out of stigma and discrimination for years, but it is still worth saying thank you to those people who have stuck with us and who are continuing, because that they do have a choice. I'm hoping that's the next thing, is that chemists and doctors won't have a choice, that they will have to see us, that we'll just be a part of the normal community as far as that goes, and that they won't be able to reject us as patients. The ministry's been really fantastic here, the Ministry of New South Wales. Ministry of Health in New South Wales. They have guaranteed that no one will be left behind, that they are working to make sure that everybody will be able to access the new rates. And I think that's really fantastic. I mean, for those people on it, I worked out that, since I've been on methadone for 20 years, I worked out that my partner and I spent around $150,000 since we first went on it, on methadone. And, those people who are on it know, at first, yeah, it's a lot cheaper than using Sure, but, it doesn't become about that. It becomes about what you can't give your children, it becomes about the future that you can't give them. It becomes about the house that you can't save for. It becomes about, the other healthcare that you can't afford, because that takes precedence. It becomes about the quality of what you eat and what you wear and where you go, and it's central, because this has to come first for us, and I think a lot of people don't realize how how scary sometimes it can be on the program to know that, if you're suddenly thrown off, or if you don't have the money, that you'll be really sick and that your whole life will fall apart. You won't be able to work, you won't be able to parent, and that's really frightening. So this is like another safety step for us, to know that, this is just another thing to reduce the stress around being on the program. I was asked whether it would increase people coming on the program, and I said, as Isha's raised, hell no, there is such unmet need already, and that's not why we join, but that's not fair to take advantage of our pain, just because, we often join in at a time when we're really quite desperate, so I think that it's an amazing time forward. I think the transition will be difficult for some, But I'm looking forward to this being, the beginning of the rest of our lives. I'm looking forward to this being the beginning of a process that brings us into the centre of healthcare, that makes us recognise that we deserve. We deserve to be seen by any doctor that we want. We deserve to go to any pharmacist we want and fill our script. We shouldn't have to travel miles because, some doctor in a country town refuses to see us, or, and now, at least we're not paying, the ridiculous, fees that we are, paying more for takeaways than we do to go, to turn up, which blows my mind. So yeah, I'm thinking, and the other thing is, with private clinics here, that there was going to be a bit of a squeeze where people were going to be moved out from, and that's they have free treatment at privates here, at the publics here, sorry, and there was a lot of fear around that. So that means a lot more people who are having to be dosed daily in the publics just so that they can get a zero fee will now have the freedom to be able to go out, work, study, enjoy life, do stuff, fill their lives with stuff other than having to go to a clinic every day simply because they can't afford the price of going to a pharmacy or a private clinic. So it's a huge day of freedom, I think, for our people. And I want to thank Kirsten very much for the work that they're putting in. And certainly, I know that state governments are putting in, to make sure that this happens for us. And so yay, I feel really good about this. So thank you.
Thank you so much, Leah. Honestly, every time I hear you speak, I get so emotional. Sharing about the fact as well that the money invested for people to just being able to access those medication to go on with their lives and be healthy and happy. So this is really a great step, and thank you for saying, for mentioning all the work that was done in the back end of this with the states and territories, and the Department of Health as well. I think to really get to this point of having a human-centered approach and to bring back people who use drug and people who inject drugs like in society, not to marginalize them and make them pay exorbitant fees that prevents them from accessing basic things. It's insane. So yes, it is a moment of celebration. Aisha, I saw that you had raised your hand. Do you have a comment that
I was trying to clap for Leah. Sorry, I didn't really get it. Sorry.
And if you have the chance and you want to see, Leah did an amazing article. I believe it's in the Guardians about that as well. If you have a chance to look that up, it's amazing. Share her story in such an empowering way and make such a huge difference for our community. Kirsten, there's a lot of things in there. Is there anything that you would like to say on this?
Thanks, Leah. I have heard you speak a few different times over the last few years as I've been working on this, and I must admit, I know that I have the departmental hat on, but I do feel this too. I do feel the emotions here in this regard, and I guess I have my own sort of emotions here to have moved this along as well. I know that there's still going to be a lot of nervousness. There's still a lot of work to do. And, nothing's, things are not necessarily going to be perfect tomorrow or the next day or, maybe in a week or two's time, but we are actively working on this as we go. And, we are working with jurisdictions. And I think, you were right when you said it's the beginning. And I think I've been sort of reflecting on this over the last couple of days too. And I think it's now time to, look forward. We've been looking back for so long about what's happened in the past and what's taken so long and how, why hasn't this worked? And we've been looking so historical for so long that I think it's actually quite refreshing to have this opportunity now to look forward, acknowledge that, yes, there's going to be some challenges. It might not be perfect right straight away, but we have a greater opportunity now, I think, to look forward and get there than we ever have. So thank you, Leah. That was it was really great to hear that. And I think for us here, have been working on this and, working pretty hard. It'd be nice that I can reflect that back to the team that I work with. They will really appreciate that.
Thank you. Can I just also say, Jonathan, so I just wanted for New South Wales peers out there to know that our peer line will be operational all weekend. So that's 1800 644 413. If you turn up at your clinic or your chemist and you've got a problem, something's going wrong, give us a call. We're working with the Ministry of Health. They've given us, sort of we're doing a cooperative thing. They've given us all the deets and what to do. And so it's 1800 644 413. So give us a call over the weekend if you get to your dosing point and you've got a problem. And thank you so much for those things, Kirsten. I think I've fallen in love with you.
Thank you so much, Leah. We will also put the phone numbers and the information in the chat, or we'll send it to the mailing list and people who have registered. And we started to send it to, MSIC and other places as well, so that everyone has the information about PeerLine, PAMS, QPAMS, and all of it, to make sure that if there's anything that people can access the information or get support if they need to advocate. But I did ask the question to David, I believe maybe it was the other day, about if there was a main info line. There isn't, but if on the pharmacist side, if they need information, they can always, I believe, call the general practitioners, and they should be able to get the information to be able to make sure that everyone can access their medication. I think it's been very clear from Kirsten and David and the department that they really want everyone to be able to access their medication. So the pharmacist should be able to do their part on that. But if the peers or consumer needs some advocacy or some support, we will give the information about the different lines to make sure that that's in place.
And the Pharmaceutical Society of Australia have also got a pharmacist to pharmacist line that they've got operational as well. So if your pharmacist is having difficulty, you could remind them of that. You should say, there's a PSA line, it's available, they are right across the issue, and they're there to help you right now. You can speak to a senior pharmacist. So that's worth remembering as well.
True. Kirsten, is there anything you wanted to add, or we covered what we had to cover about this?
I think that's all in that regard, but yes, in terms of other supports, I know that pharmacists and prescribers can also call Services Australia. They have lines too, if there's issues from the kind of dispensing, PBS dispensing side. So I think there are multiple avenues available.
Thank you for that. So I'm going to go to Sarah. So Sarah is an absolute superstar and manager of PAMS, the PAMS program at AIVL, so Harm Reduction Victoria. Could you tell us a bit more, Sarah, about what's happening in Victoria, what the realities are, and if you have any question for Kirsten?
Yeah, sure. Thanks, John. Thanks, everybody. I've got the lucky. I'm lucky I can get the to go last. So, look, just briefly, I'm the program manager of PAMS. We're a statewide service. We're funded by the Victorian Department of Health. We've been in existence since the early 2000s, really, and we deal with any pharmacotherapy client-related issue. So we only work with people who are opioid dependent. We help people start, restart treatment, and we also resolve problems that anybody who's on a program might have. And so over the sort of 20 or so years that PAMS has been running for, historically, probably the most commonly reported issue every year relates to the cost of the program. Mm-hmm. So it's ranged, it's probably sort of about anywhere from about 20 to 28% of all our cases relate to payment at a community pharmacy as the primary reason that people are calling us. And that might be that they literally don't have enough money to get that next dose, or they've got a dosing fee debt with their pharmacist, and the pharmacist said, that's it, no more, no money, no dose. The number of times I've heard no money, no dose, oh my God. So it's huge. This change is just so massive. I was so sort of like, oh, it's never going to happen. I started saying, I'll retire the day it happens. And now I'm like, oh, we're there. It's happened. So I would really very much like to extend my thanks to everybody who has made this happen. To be totally honest, I was quite shocked when I heard it. I didn't believe that it really had happened. And I held off from telling any of the pharmacotherapy consumers because I was just terrified that there might be a change or it might be reversed or delayed but we're here now and it's just amazing. And so, yeah, my most sincere thanks. And I guess sort of to move on to what's sort of happening in Victoria, I would probably say it's fair to say that a large number of pharmacotherapy clients, people on program, don't actually realise this has happened or happening or about to happen. We've actually got a information sheet that we've sent out to every Victorian pharmacy to let people who are on the program know that this change is coming and that it does start tomorrow, and what it means for people on program right now and what they have to do to be able to get that change. So I'm happy to send that out to anybody, but it should be going to every Victorian pharmacy. I've had a few people, there's been a bit of confusion about prescriptions. In the first place, there was a little bit of confusion as to whether the electronic scripts were going to be able to be transferred across to the new system, but we're now aware that they absolutely are and how to make that happen. So there was some confusion with prescribers telling people that they would need a new script. I'm really hoping that by now, the day before the change is about to happen, that most of the pharmacists and most of the prescribers at least know what to do or know where to get the information that is going to tell them what to do. We haven't been inundated with queries from pharmacotherapy consumers yet, but I reckon that's probably going to start to happen over the next sort of few weeks. Every person that I've spoken to on a program that I've told them about this haven't actually known. I've been the first person to let people know. But yeah, I think in terms of pharmacies, we've had about 9 pharmacies in Victoria. Victoria is different because we're entirely community-based. So we have no public clinics, we have no private clinics. It's an entirely community-based model of service delivery in Victoria. So all prescribing is done through general practitioners, nurse practitioners, through a lot of community health services and what are referred to as private prescribers in other states. And almost all of the dispensing of pharmacotherapy is done through community pharmacy. So the PAM service and the PAM staff work a lot with prescribers, pharmacists, and of course people on program wanting to get onto program. So yeah, we have had a few pharmacists that have been quite concerned. I think for pharmacies, the really in some ways the biggest issue has been the timing of this implementation of this change, and that it's come so close to what pharmacists are feeling will be a really negative impact from the 60-day dispense. And I think that's been difficult for a lot of pharmacies, where we are a little bit concerned about some of the smaller rural and regional pharmacies. There are parts of Victoria where there's literally very little, if any, public transport. So we've got some concerns about just in terms of people accessing program and being able to get to a pharmacy to dose. If there is a small pharmacy and it does decide to close program, or worse, or even not so much close the program, but if the pharmacy does shut. But we're also fairly hopeful that possibly pharmacies that haven't been involved in pharmacotherapy service delivery previously might come on board. So we absolutely see this as a really positive change. I'm acutely aware that some pharmacists are really concerned about their ability to maintain service delivery, but I mean, the number of people that I have spoken to over the years through working on PAMs, and we have been able to provide small amounts of financial assistance just as a way to keep people dosing. Program continuity is one of the primary goals of the PAM service. Of course, if that's what the person that we're working with wants. But yeah, just coming to the realization that I'm no longer going to have to say to people, look, it's got to be rent number 1, methadone number 2. and pay in advance so that you know you can get your methadone. The realization that we're not going to have to even say things like that anymore is just really so substantial, so amazing, you know. And I felt terrible having to say that to people, but you know, and that's awful that people have to actually pay in advance for their medication. But when you're on a government benefit and you're paying between 11 and 15% of your entire income on one medication that is an essential medicine declared by the World Health Organization, I'm preaching to the converted, I know, but this is all the stuff that's going to change, and we're just so excited about. And mega thank you, huge congratulations to everybody at the Commonwealth Department of Health that's made this happen, and to all the Victorian pharmacists and prescribers. We know this is going to be difficult. We're here to, you know, we're here to help. We've got to kind of all hold each other's hands and do this together, really. So
yeah, that's
where we're at. And I guess that, as Leah said, you know, I probably should promote the PAMS 1-800 number, which is 1-800-443-844. So if anybody does have any problems with this change in Victoria, give us a call. We're happy to help. We'll literally speak to your pharmacist or prescriber and talk them through the situation, link them with the people that they need to be linked to get the information that they need, and we'll make sure that, you know, nobody has to go without a dose. That is not what this is about. So thank you.
Well said.
Thank you so much, Sarah. That was an amazing overview, and it feels so good to know that you won't have to say that anymore, and that we can move forward finally. And thank you for sharing about the system in Victoria. I think Kirsten and David had a lot of different conversations, I believe, with pharmacists and GPs, and there was a webinar this morning as well. Maybe Kirsten, could you let us know how it went, and if you feel that pharmacists are ready to take on this challenge?
Yeah, absolutely, yeah. Look, I think personally, what I think is once the pharmacies get through to the end of August, and they're getting in a big check from the Commonwealth Government at the end of every month, then hopefully we'll be there. And it's just, you know, I attended the PSA, Victorian PSA Forum last night, and it just made me realise the detail and the complexity and the nuances of all of these changes. They are incredibly detailed, and to make this work, you know, there's so many little bits, but you know, at the same time, that's pharmacotherapy. You know, it's dot the I's and cross the T's. That's pharmacotherapy. That's the area that we work in, and it's different, you know, for all of us. I think the consumers, the pharmacists, the prescribers, we've all got our role to play to make this happen. But I think, yeah, I think it is just everybody getting used to a new way and a huge change. And once we all know what we're doing, we'll be fine.
Yeah.
Thank you for that. Kirsten, is there anything you would like to add about the pharmacists?
Yeah, so we have been talking to a lot of people over the last couple of weeks. We've been meeting regularly with the pharmacists and with prescriber groups as well. We did have a couple of webinars this morning, so that we had one with prescribers and we also had one with pharmacists, and it was a bit of a Q&A, so they were throwing all their questions at us and we were answering them as best we could, with as much detail as we could. And yeah, it's been a bit of a tricky bit to transition from kind of current state to a new state, but that was always going to have to happen. And you know, it wasn't like what sort of happens now is the same as where we're going. So there was always going to be this transition period. We've put a lot of things in place to support pharmacists to do that. So we've got fact sheets, we've got a dispensing workflow to help them with all the steps that they'll need to do over the next week and starting tomorrow. We've got calculators to help them support them to transition your existing scripts into the new PBS arrangement. So we've done what we can, I think, to try and help them support them to do that. We know jurisdictions have starting to produce kind of example prescriptions with how to write an ODT script in a PBS way. and they're publishing those so that people can share those. So, and I think that's really helping prescribers wrap their head around this kind of new way. But yeah, it will take a little bit, and I think that Sarah's right. Once we kind of get into a rhythm with this, and pharmacists start to receive remuneration in a different way than has happened before, but nonetheless in a way that they're familiar with. So pharmacy is quite familiar with making claims to the pharmacy programs administrator for other community pharmacy programs that they might do and other services they provide to their clients. So it is familiar to them. It's just going to take a little bit of time to roll that out. I do just want to confirm though that all scripts will be able to transition. So that is paper-based scripts, and if you have an e-script, that is okay. We did have a little bit of trickiness with that in the beginning, but we managed to iron that one out. So, and we've definitely communicated that with both the prescribers and the pharmacists. So I hope that they've got enough information that they're going to need, but we've certainly had a lot of communication forums over the last few days with them. So.
Thank you so much, Kirsten. And again, I want to reiterate that we're going to make sure that we give the information about the different peer lines on PAMs and QPAMs to have all the numbers ready for everyone who's registered today, but we're also going to make sure to send it through our mailing list. We're getting to the point where it's questions time. So I just want to let you know that, of course, as I said at the beginning, it's a safe space. So you can feel free to ask any questions you have. And just be really respectful and constructive on how you're asking it, just to honor that, it's a safe space for everybody. Also, it is recorded, so if you're just joining us, just know that it's recorded for privacy reasons as well, that you're aware. So if you have a question and we don't have time to answer it, please pop it. There's a Q&A section at the top of your Teams software. You can click on it, pop down the question, and one of our team member can answer. And we're going to have the script at the end so we can continue answering those questions with people that have been with us today. So I'm going to enable everyone to be able to ask your questions. Let's do this. So I'm allowing everyone to use your mic and camera. You don't have to use the camera if you don't want to, but just so you know, from now on, you're able to use that to ask your questions. Does anyone have any question for Kirsten or for any one of the panelists? You can click on raise your hand at the top, like I'm doing right now, so we can see who has a little question.
We must have explained everything really well because no one's got any questions for us.
So as I said, if you have a question, just click at the top. You have the raise your hand button. You can just click on there. Let's see. Any questions are welcome. No problem. It's your chance.
Oh, we got one person.
We have a question from Richard. Richard.
Hi.
Yeah, hi.
Mine's I'm a consumer. My concern is the payment. Now, on the first day, I have takeaways, which I go in on Monday then to get my next lot. So as of Monday, my scripts are all sorted, and I have a grace period. We worked around the system of 3 months. I'm in Queensland, and with the payment system, do I, on day one, I go in, do I have to pay the $7.30, or will the old payment system cover me until the end of that payment?
Good question, Richard. We're gonna go to Kirsten as it's a more technical question.
Thanks, Richard. We do know that there might be some situations where people have paid already in advance for their dosing. So pharmacies have been up until now continuing to receive free stock for clients. So it's probably up to you to have a conversation with your pharmacist about how you would like to do this. So it might be that they might decide to work those payments back to you and then you pay the co-payment, or you just continue on for a little while until you hit the end of that point and then you start the PBS. I think because that's sort of something that happens at an individual pharmacy level, you'd probably have to check in with your pharmacy about that. But, you know, I think it's important from our perspective that people start to move towards the PBS arrangements as quickly as possible.
Thank you.
Thank you so much, Kirsten. Is there any other things the panel would like to add?
Yeah, I mean, if people want to, you know, negotiate, for example, sort of repayments, so if they've paid, you know, enough in advance and they want to be able to negotiate with their pharmacist, you know, about that, and they're not quite sure how to do it, they can ring, you know, Peer Line in New South Wales or PAMS in Victoria, and or the drug user organisation in your other states, and get some support to do that. We're not always great at advocating for ourselves because, you know, we're really not used to getting great treatment. So there's a reason for that. So if you do need support to be able to do that, give us a call and we can, you know, intervene. We'd like to talk to you about a way to do that, or actually, as Sarah said, talk to your pharmacist directly and try and negotiate that for you.
I would like to echo that as well. Like, I know it's hard sometimes to advocate for yourself. So if you need some help, please call those lines to get a peer to be able to help you. Because especially when it comes to money, we all have different relationship with money and, you know, our needs. So make sure you get someone to support you if you need so. We have another question. I think it was from, was it Nadia?
I think so.
Yes.
I wasn't sure if you were going to be able to hear me because I'm in the tropics. But it wasn't really a question. It was more like, you know, my family, I go to a very, very small pharmacy, and they were really quick at, you know, realizing that change is going to happen. My normal pharmacist wasn't there, so, you know, the casual pharmacist sort of did make me wait because she wanted to make sure she crossed all the T's and dotted all the I's. But I was actually surprised at how quickly that they're able to, like, they were just like, you know, because I'm not on I don't have a healthcare card or anything because I work. But they were like, "I'll just start paying that from now," even though it was prior to. So instead of paying $84 every fortnight, they're like, you know, let's just start it from now. And so I just paid the $30. Yeah.
Oh, wow, that's so fantastic. That's amazing to see that there's really some pharmacists and some pharmacies that are really ready to take this on from a human kind of centered approach. That's really good to hear. Thank you so much for sharing that from the tropics. The next question we have is Carlia.
Can you hear me?
You're very faint. I
Oh,
don't know.
sorry. How's
Oh,
that?
perfect.
Good? Okay.
Yeah.
So I am calling from Wanata in Western Australia, the peak body for the AOD sector. And
Yes.
we are just wondering if we're not aware of whether there's an information line here similar to PAMS. There hasn't been a lot of information provided for us. So do you have any idea where consumers can get information about the changes specific to the West Australian context?
I'm not sure if in Western Australia there is a line like we have in some other states. Aliyah, did you have
I was just going to say that, I mean, they could just directly call Harm Reduction Western Australia, which is a drug
Yeah.
user
Yeah,
organisation.
peer-based
Yeah.
harm reduction.
Yeah, I also work there.
All right.
Okay, all right. So they might know a bit more then.
There's
I'm sure
also
Paul's across it.
there's also the community opioid pharmacotherapy program, the community pharmacotherapy opioid program in WA, CPOC. They should be completely across this, and they should know what's happening. We deal with CPOC a lot when we're doing temporary interstate transfers.
Okay.
That's the point.
You are the queen. You are the queen, Sarah.
You are
Thank
Sarah. Go
Precious
for it, Sarah.
information. Yeah, that's amazing. Thank you for that. So I think the next question is from Brylan. Brylan? I'm so sorry with my French accent. It's not always.
It's Breland, that's fine. Brief is short. Hi, I'm in Newcastle in New South Wales, and I'm on at a private pharmacy. I had troubles logging in. I'm wondering if you have any information about what's happening with private pharmacies and the PBS, and because yeah, from my understanding, they're trying to phase them out. But yeah, so I'm just wondering if you have much knowledge or information you can give me.
Thanks, Bree. Leah, do you have any information that you know about that?
So basically, I think that they're saying in the short term, people may have to continue paying that price, but that they do have an option for applying for the PBS to be PBS providers, yeah. And if they're not going to, we're working on being able to transition people to new dosing places, and so yeah. That's kind of my best advice would be to ring PLI and get them to support you to move to a new place. But I think probably Kirsten's got a bit more advice around that.
Yes, Kirsten, do you have anything to add?
Yeah, so in the sort of, I guess, short to medium term, we are continuing to support those private clinics to access the medicines so they can keep supplying the clients that they have, knowing that, you know, the transition isn't going to happen immediately overnight on 1 July. It just means because they're not part of the PBS system that you may need to continue to pay those private fees until you can move into a PBS kind of setting, or they make PBS arrangements. So we are working closely with jurisdictions to make sure that people in those settings are supported to safely find another spot. So we have had very strong conversations with them that no patient is kind of to be kicked out, or, you know, the doors, they're just going to rock up one day and the doors will be shut or anything like that. That would be completely unacceptable. So we are working really closely with the jurisdictions on that to make sure that how those sort of services move into this new PBS model is done in an appropriate manner. I think too, some of the clinics that we've been speaking to are kind of rethinking how they do their business. I think, you know, up until now, a lot of them have been running their business purely off the fact that they can charge really high private fees.
Yeah.
And that's been the only way that they've been able to keep their doors open. And in fact, that's probably not what we want going forward in a model of care. We want people to be able to get access to PBS subsidised care. So I think some of them are rethinking how they run their business and what that might look like. So it might not mean that all of them decide to eventually close their doors and move on to something else. But I think we've got until the end of November that we're running those transition arrangements with the private clinics and other non-PBS kind of dosing sites. So we do have some time to work that through with them.
Thank you. Thank you.
Thank you so much, Kirsten, for that. The next question is from Justin.
My God, the French pronunciation of my name, for heaven's sake. Hi, gang. Just touching base from what you were talking on there about, you know, with my experience of being, you know, have done my time on being in clinics and doing my time on being in pharmacy, and how different that can be and feel. I know that there's a lot of people still going to clinics, and very much connected to what you were just talking about there, about how basically, you know, a lot of those clinics has got, you know, the BMWs and the Volvos parked up out the back that I think a lot of clientele see, to see that they're extra. It's kind of like people have been able to charge pretty much whatever they like, and there's been no equality with that at all. So that's that's really great to see this day coming. But my concern is kind of like with a lot of those private clinics going, okay, so we're not going to make money anymore, so therefore we're going to close. I was just wondering what people see as kind of like how that's going to happen. Do you reckon that kind of like all private clinics will close? Do you think that just some of them that will still be able to make enough money to go? And I suppose my main concern is with all of the people that are being seen and supported through private clinics, will there be kind of like a bit of a tidal wave of them trying to find places in community that might be full up in their pharmacies at the moment, so that they're kind of like going, where will these people go?
Can I comment to that? Hi, JT,
Yeah.
by the way.
Hi, buddy. Nice to see you.
Hey, good to see you. Hey, look, I'm just talking from the people, the consumers in Queensland, and that's what they're really scared about too, you know, like, so
yeah.
When I estimated, I think there was like 2,500 clients that get prescribed by or get dosed by our private dosing clinics. And with the ATODs, you know, there's such a wait list. You know, if people are getting out of jail, and there's a 3-week wait list to be able to get an intake, like this is like my main concern is what's going to happen to those clients if those private facilities close down. So my question is exactly the same as yours for Queensland, which like we're quite worried about, you know, like that's 2,500 clients that can't even get dosed by ATODs because their wait list is 3 weeks to get an intake for someone getting out of jail. This is the thing. So
it's wonderful news, but meanwhile, there is going to be, you know, a bit of a wave of people trying to find somewhere to go. And do we have the capabilities to people to go, don't worry, we've got you? Or are we going to be in a bit of a glut of going, shit, where do we find places for people to go in community?
That's 100%, yeah. And I don't know what the answer is. Like, I'm on the QPAMS line, and when I have clients ringing me, I feel really, sometimes I don't feel like answering it because I've got nothing, like I don't know what to say to them, and it's really damn hard. I'm telling you, like, what do I say? You know?
I suppose we're just going to go with the information as it comes to hand. Has anybody else got any kind of like overview on what they think they see, how that might start to look, or if there's any support around that wave that's bound to happen, trying to get
Does anyone know that we're going to have any IST, you know, heaps of doctors come to prescribe us in Queensland? Any chance? Anyone knows?
Thank you so much, Bob, for sharing about this. Kirsten, do you have any insight maybe about this? It's a bit of a tricky one.
Sorry, Kirsten.
No, that's okay. Look, on that, I'd just say that, you know, we do understand that it is really hard to find places sometimes, but we have been having those conversations, and we started having those conversations really early with the states and territories about what do they need and how much time they need to do this. And so that's why we've got this kind of 5-month transition period. They came to us, including New South Wales and Queensland, and said, look, we think that we need about 3 to 6 months. And we obviously sort of didn't want these transition arrangements finishing like 31 December in the middle of the Christmas break. So we sort of bought it just before that time. But that's what they said they needed to make sure that patients can be moved towards PBS arrangements, or that those clinics can.
There's an extension to November, isn't there? So it's basically between now and November, that should be time for private clinics to kind of like get it together to make sure that they can support people through to where they need to go. And hopefully there's not too much of why am I imagining a tidal wave? You know, it's just because you work in the sector and care about our peers. So yeah, hopefully that won't be the case.
Yeah, and they're giving us advice really regularly about how they're managing that, and we will be working with them over, you know, now that we've gotten to sort of the 1 July point, we're going to be really working very closely with them over the next few months on that implementation planning and making sure that works in a smooth way. I think there are some clinics though that they're not just purely a dosing point. They
This-
run a whole range of services, and
Well, this is, to be honest, one of my main concerns. There's so much, it's going to be interesting how the space changes actually, for kind of like supporting consumers and peers around getting all those extra healthcare pathways that are going to be changing into kind of like a pharmacy type space. But yeah, be happy to keep in touch with anybody here today, kind of like going forward about how to continue supporting people that we would often get to spend time with in these clinic spaces that are going to be changing. Thank you.
Thank you so much. And I was talking with Stephanie a few days ago, and they're working so hard in New South Wales to make sure no one falls through the cracks. And I think really the states and territories are communicating with the department to really try to make this happen in the best way possible. But there's definitely some challenges. I think more than DODTP, there's just other challenges that need to be looked at as well. And that's what Kirsten was mentioning at the beginning.
Yeah.
We just need to continue working on this. This is a great step.
Yeah.
And this is kind of, it's giving us energy to be able to keep going and continuing asking those questions and working with the different like health departments and to make this happen. There is some really nice questions in the chat. Before I go to Richard, I'm just gonna say on the AIVL website, there is some new information that Ellie put some time in to make sure that it's really good for consumers. So if you want, you can have a look there. There's a lot of good information on the medications in the community pharmacies. And also there was a question from Kat about, we're going to change government at some point as well. So will this continue to move forward with the PBS inclusion?
I assume that's one for me, John. And the absolute answer is yes. So these medicines will continue to be funded on the PBS. That is certainly not going to go away. That is a decision of the Pharmaceutical Benefits Advisory Committee, and that has been agreed by government and implemented. So that is definitely not going away. I will also say in regards to the funding that's being provided to community pharmacies, to support this, and so they can be paid for the daily dosing that they provide you. That funding is uncapped and it's ongoing. So it will not stop midway through a year and we've suddenly run out of money. There is funding available for as many patients as pharmacies see. And I think that's another aspect that is quite positive in this space and is, I guess, a little bit different sometimes than other programs operate in the Commonwealth, because they usually have a limit, but this funding is ongoing and it is available for as many patients as pharmacists will see.
Thank you so much for saying that. Ellie mentioned that in the chat as well for everyone to see. I think it's so nice to hear that and to hear that this is an important objective from everybody involved, and that it's just the committee is behind all of this and people in government as well. It makes a huge difference for all of our community members really, and all of our amazing peer workers that like Aisha and other people that are working, telling people, helping people on the lines. So I'm gonna go to Richard if we didn't answer your question already, Richard.
You sort of have, but I just have a slight comment about the ongoing care problem that people may have if the clinics close down here. And keeping in mind, I'm not a professional in this area, I'm just a consumer. So I don't know what other states operate at, but we have in Queensland a thing called shared care. And I use that facility where I initially presented at a clinic, and then they trained my GP to take over my care for ongoing. And I don't know if that's an option in other states, but it works well for us, or for me.
Does anyone on the panel? Yes, Leah?
Certainly in New South Wales that can occur. So your GP can certainly take you on. The problem that's happened down here is that a lot of people in our community don't actually have a GP, and there's not a lot of people who are bulk billing at the moment, which means that people find it hard to keep the same doctor ongoing. But But yeah, I think it's a great option, and I hope that more GPs will step up to that.
Thank you for saying that, Leah. That's very true. Also, just to let you know that Adrian posted in the Q&A section as well the link to the PBS website, link to Harm Reduction Australia website, and the link to the AIVL website as well. And we're going to keep on posting the different websites so that you have access to all the information if you need. Let's see if we have another question. Does anyone else have any other questions? Any comment from the panels? Anything that you have in mind?
I just want to thank the other panelists for their information today, and for Leah as well for a wonderful story. And I think it was The Guardian, wasn't it? I'm not 100%, but it was very touching. And
Herald, yeah.
Just reading that story was really touching regarding how much money we do spend on pharmaceutical benefits, and we don't realize when we're paying that, like every week or every month, and how much it actually adds up. And I know this new system's going to really benefit people. And just exactly what Sarah was saying, where you're trying to say, like, listen, paid for your rent and then paid for your dose, and it's really sad when you have to say that, and so it's going to help. I know it's going to help a lot of people out financially, especially people on Centrelink or something, so maybe they can just go and spend some more money on food or something else, because there's such a crisis at the moment with everything. So I know it's going to help, but it's just trying to get through this period at the moment, and then it will work out. I suppose it's just with anything new that happens, it's just people aren't, and I feel that a lot of our clients aren't used to change, because this is what they've been doing most of their lives, because they've been on the program. So it's all got to do with change, and I feel that we just need to support our consumers just with that change thing, because if it's affecting us as people that are trying to help them, it's going to be affecting them more. So but I'd like to thank the other panelists as well. I think it's really touching what they said.
That's very true. Thank you so much, everyone. Sharing all the work you do as well, like being on the line with people, or helping people out this way, just makes such a big difference in the end. Like, the work that people do on the front line is so important. We have another question from Kat.
Can you hear me?
Yeah.
Oh, great. I have a microphone but no camera. Sorry, everyone.
Yep.
I'm really heartened that this has happened. I'm wondering why it took so long. There are many of us elders in the movement who have been advocating for this change for many, many, many years, and pushing back against that really harmful rhetoric and that really harmful narrative when people say things like, well, if you can afford $100 a day for heroin, then surely you can afford $30 a week for methadone or Suboxone or buprenorphine or whatever, which we all know is utter rubbish, because when you get onto a pharmacotherapy program, you're often not doing the hustle and the scamming and the stealing and the sex work and all of those things that go alongside. And hey, if you still are, no shame, no shade. But I'm really interested as well in how this came about. How did this happen? Like, I'm so glad that we're here, but how did it happen in 2023? Do we have any time for a little bit of story time to let us know exactly, how this began, who our champions were? What was the pathway? Thanks.
We definitely have some time for this, because it's important not to forget that this is a big step forward. And sometimes, because transition is scary and there's a lot of unique realities and challenges, we can forget that. And I know Kirsten and David have been spending all week having those very difficult conversations, and there's just so much amazing work for so many years that went in this, from advocates, from peers, but also from people in government like you, Kirsten. You were sharing a bit at the beginning that you really wanted to make sure this would happen. Do you mind telling us a little bit about this?
Of course. That's a great question, Kat. I was sharing before we started this session today that I've been reflecting back a little bit about that over the last week. So I think, this is not just come about from one particular different angle. I know that, you know, there is probably a lot of people on this group today who have been advocating for this for most of their lives, including Leah. I know that we've been working with harm reduction and AIVL over a long period, and they've been really strong in advocating for this. I think one of the big impetus here in the recent years has been doing the post-market review of these medicines, and a strong focus on reviewing this program and looking at it from a number of different angles. One of the big parts of that review was engaging with consumers who participate in these programs and hearing your stories. And we worked with AIVL to do some consultation a few months ago. I think it was just before Christmas on that. So there's probably some people potentially on this call today that participated in that and provided information into that. And including that report into our review was really, really persuasive for government. So I think you have a really strong part to play in this, and you have pushed it forward as well. From a kind of bureaucratic standpoint, you know, there's a lot of changes going on for pharmacy at the moment, and government really wanted to invest money back into pharmacy. And so opioid dependence treatment was one of those focuses. So, you know, it was kind of a little bit opportunistic that we saw the opportunity and we took it. And for some reason now just seemed to be the time that worked, and we didn't let it go. So I think there were a number of different things that kind of seemed to come together. We also had a really strong push to get legislation for this registered by 1 July, and that added to the mix here. So I think it's been just a combination of things that have happened. But certainly in my time working on this, doing the review that was really, really comprehensive. We heard from a lot of different stakeholders. We worked with experts on a reference group to input into this. That really drove this forward. So I think it's, you know, it's part that, but it's also thanking everyone here for their contributions and the personal input that they had to it. So thank you.
Thank you so much. It's such a community effort, and to know all the peers and consumer that we represent through, you know, the AIVL network, and all the work that have been put into this. And I'm thinking as well, of course, of Chris and Annie that were part of the post-market review and worked so hard on this. I don't think they're here today, but I want to acknowledge the work they've done. I want to acknowledge the work that people at, you know, at PAMS, at QPAMS, at NUWA as well, with Peer Line are doing every day to help people, but also all of our member orgs that are just amazing and represents hundreds and thousands of people in so many different diverse communities and with different realities. And there's just so much effort to combine that energy to be able to create change, because people use drug in Australia and across the world quite often, and people who inject drugs particularly are really left on the side and considered sometimes as not even being part of society, which is absolutely unacceptable. And it's so nice to see this change happening, to kind of reconnect and feel that we're part of society and that we can keep moving forward and support each other and be stronger and take that to keep moving forward. So I'm just so happy to be part of this, and I appreciate personally, and in AIVL's name, thank you to everyone that worked on this to ensure that people wouldn't be left behind and not being able to pay their bills or their food because they have to pay for medication that is essential for them. And thank you to anyone from the government that took this as a human to heart and wanted to make this change and push the bureaucratic side to get this done. So thank you so much for that. Sorry. And I think Kat, did you have something to add, or the hand was just raised still?
No, I've got something to add. That was a wonderfully passionate little speech, John. Thank you, Messi. I wanted to ask if on the panel or on the call today thinks that this change, this long-awaited, much-needed change, could potentially provide sort of broader scope for the lessening of stigma and discrimination for illicit drug users in society, or even for you know, if we could sort of like springboard from this to you know, create you know, stronger pathways or more pathways to you know, rehabilitation services, or you know, addiction really being recognized as a, you know, potentially a mental health issue, or as certainly as a human rights issue. So do we think that this, you know, this could potentially you know, lead to better outcomes in other areas?
Yeah, I fully agree with you, Kat. I was going to say that. I was going to say, hopefully, after this rolls out and everything calms down a bit, that, you know, like people who use drugs or people who inject drugs, maybe the pharmacists and doctors and pharmacist assistants and prescribers and whoever else in the healthcare system may treat us differently, because it's going to be, I feel this rollout is going to make people who use drugs or inject drugs a bit more normalized, you know, and we're not just those people that have to stand at the back of the pharmacy, etc. And hopefully the stigma and discrimination might calm down just a little bit. Well, you know, I will know it will never ever end, but hopefully in my lifetime it will calm down a little bit and we get treated to proper healthcare services that we need.
Yes, I think Sarah as well.
Thanks, John. Yeah, look, one of the things that I wanted to say is over the last 10 years, I guess one of the biggest changes that I've noticed in terms of service users at PAMS is really who they are and who is actually on treatment for opioid dependence these days. And it's not just your typical injecting heroin user, which is what it was 20 years ago. There are many, many people who have become dependent on over-the-counter codeine, for example, prescription opioids. They're, for whatever reason, have become opioid dependent and are wanting to access the treatment for opioid dependence. And this cost issue has been a huge barrier. It's crazy that, you know, you can get OxyContin, oxycodone for $7.30 for a 28-day supply, yet methadone, the treatment for opioid dependence, actually was costing more like $140, $150 at a minimum for a 28-day supply. And one of the big problems that we had is people who were dependent on prescription opioids and had difficulty continuing to access prescription opioids for whatever reason. The doctor had retired or resigned and couldn't find another doctor, or specialist had told them they had no choice. They had to access, you know, pharmacotherapy. And they were, you know, like, and people were just absolutely astounded. Like, what do you mean I have to pay $140, $150 a month? That's crazy. Why would I do that? And now that we've got equity between the cost for somebody with a healthcare card or without a healthcare card, those two medications are going to cost the same amount. And I think that's fantastic. And I think it does. I think this change could go some way to reduce or address stigma and discrimination in some way, because this pharmacotherapy treatment user population are not sort of seen as different. We've got equity with other PBS medicines, and I think that's huge. But just a comment, really.
No, but thank you both. It's that we're moving in the right direction, and there's going to be other challenges, but at least that this is happening kind of gives us that feeling of equity, and hopefully is reducing stigma slowly. I think that there's going to be a lot more action that we can take after this to continue reducing stigma. I think there's the power of our network, the power in numbers, that there's 3.4 million people using drug in Australia. And there's a lot of people as well injecting drugs, and we need to represent them fiercely and support them fiercely. And I think that we need to work closely with people in government and other agencies to be able to make those changes and change people's perception of people who inject drugs, people who use drugs. But this is a good step because I don't really like the word normalizing, but I used it before, so I agree with Aisha that it kind of normalizes, it brings people back within community, and even though they were always community, but in terms of perception. Kirsten, did you have anything to add to this?
Sorry, John, just finding my mic button. Yeah, I mean, I think that's been one of the focuses we've had, is trying to bring this into line with more usual PBS arrangements. And certainly that's been our focus in terms of we want people to now be able to access this and have this subsidised through the PBS as they would for any other medication, and not keep it in this kind of separate thing on the side. And so, you know, moving the medicines onto the highly specialised drugs program, which has been operating for a really long time and is well established, helps with that because there's already a way of doing things for pharmacists. So there's some familiarity there. And I think, you know, we would like to see that over time this becomes part of more usual pharmacist practice. And hopefully that means that there's more participating and then more people can access the care that they need. It's always seemed very strange, as Sarah pointed out, that you can get PBS prescription medicines cheaper than you can get the treatment. We've heard that really strongly over the last few years. And you know, it's something that we've noted as we've been working through this, and obviously a significant anomaly in our system. So I'm glad that we can actually rectify that now.
Yeah, absolutely.
Thank you so much for saying that. And I think it's to bring that back as well to that human-centered approach, to that health and human rights approach. That is where we're at, is that people that use drugs, people that inject drugs, people that live with EPC, or, you know, have been cured with it. We need to focus on that human rights component to make sure people understand where we're at, that needs to change, that we are part of community and society, and we need to be acknowledged as such. So it feels amazing that this change is really going to create that first kind of, not first, but one of this first feeling of moving forward together. I just want to say there was some really beautiful messages in the chat as well. Let me find it. There's someone who was saying that they were able, because of the medication, they were able to actually finish university. I thought that was important to acknowledge that, you know, those medications are really helping people not only surviving but thriving. I think it was Tanya, just found it, Tanya with Suboxone. And then Ellie also posted in the chat the number for Hepatitis South Australia, their clean needle syringe program, and also Health and Community Services Complaints Commissioner. So if you need to call for that, the numbers are in the chat. Do we have any other questions from the audience? I think that's it. Leah, I would like to ask you, because I've worked with you at NUA and you're such an incredible person. Would you like to give us a little comments on where you think we're at with the human rights of people who inject drugs in Australia, to finish on a human rights advocacy moment?
Wow, that's big. You know, for a long time, you know, we've been looking at, the approach has been around the legal system, and then, the healthcare sort of aspect, which is really important. But I think the most important thing is about who we are as people, you know, that we are important parts of the community, and that we're not the same as each other, we're not a stereotype, that we using drugs and our drug histories or whatever is just a really small part of who we are. That we are, you know, amazing people. We're parents and friends and workers and creatives, and that we, you know, input the very large conversation of, you know, who we are as a nation and as a world, and we push all that stuff forward. And we're incredibly important people in the scheme of things, and we need to be seen and we need to be recognised, that, you know, that we aren't, that you know, the drug use thing is really, you know, such a small part of who we are. And you know, the only way that we can kind of move ahead is you know, when that sort of stigma and discrimination about, you know, about drug use is actually put to the side, and people start looking at people as individuals, and as, you know, the wonderful creations that they are. It sounds kind of a bit wet, but I kind of think it's really important to remember. So I think my community is just the most amazing community, you know, of people who are just so incredibly smart and insightful and kind and generous and thoughtful. And you know, I'm really proud to be part of this community. And you know, and I would like everybody to listen to us and to see us as we see ourselves. Thanks, John.
Thank you so much, Leah. Honestly, I knew it was a big ask, but I knew you would deliver as always. Thank you for saying all of that. I really appreciate it. And I think it's so important to just not see us as well through the, you know, the BBV, STI, or the health angle. Like, there's other ways to help us as well. I think the AOD branch and other branch can support us, because people use drug are such a diverse community, as Leah was saying. So definitely we appreciate the support. Thank you so much, Kirsten, for your time today. David wasn't able to join, but you stepped up and gave us some incredible information, and we really appreciated taking the time as well just before the implementation, so we're on top of everything. Thank you to all the panelists. You were so amazing and giving us so much information as well about your realities and what you're doing and working on and how you're helping people. Again, I would like to remind people that if you need anything, if you need support, there is PAMS, there is QPAMS, there is NUA, the peer line that you can call if you have any need. And if you don't know who to call, just call your drug user organization. They will be able to you know, help you in any way they can and direct you to the right services. So we're here for you. You're not alone. We're there to make sure that the implementation is done great. AIVL has worked really hard with the department to ensure this would be done very in the best way possible as well. So if there's anything, you can reach out to AIVL too. And all the questions that we haven't answered or that are in the Q&A, we'll make sure to compile all of that and send that to everybody. And we will make sure that you have all the information. And don't forget to check your drug user organization website. The AIVL website has a lot of new information as well. And I believe, if I remember, Kirsten, let me know if I'm correct, but on the PBS website, it keeps on being updated. So if there's any changes, they keep on updating it. So it's not because if you looked at it 2 weeks ago that it's the same exact information. It may have evolved a little bit. So make sure to keep having a look on that, especially if you work for one of the organizations helping people. And on that note, thank you so much, everyone, for being here today, in the audience as well, for your amazing questions. And thank you for allowing me to do this with you today. And I hope you appreciated my accent.
Thank you, John. Thank you. Bye, everyone.
Thank you so much. Thank you so much, everyone. Have an amazing weekend.
Thank you.